So we're going to talk about challenges and opportunities, kind of with an ethical eye. Hopefully focus as much on opportunities as challenges, but there are a lot of both. I thought we'd start by picking up, we mentioned before 23andMe, this company where you can get your genome sequence, get the data given right to you, and you don't have to go through a clinician to do it. So that raises a lot of questions that I wanted to hear each of your opinions on, especially if there's a strong one, and how that, because this is a challenge that's, a lot of what we're talking about is sort of abstract, and this is right before us right now. Should people be doing this? Should I be doing this? What's the good and bad?
Well, I have not been a big fan of 23andMe, partly because I worry that people are still going to spit in a cup. This is the spit in a cup, send it off to the company, get back information, sometimes about ancestry, sometimes about your disease risks. And I guess the FDA recently said that for 10 tests, they could do that without counseling, or they didn't need to have someone interpret the information. So the first point I would raise is I still don't believe that people know how to interpret genetic risk information. I think their doctors aren't sure, they're not sure. If somebody says to me, you have triple the risk of this disease, but the disease is exceedingly rare, it doesn't take a lot to make me worry about something that I shouldn't be. Second, I worry that some of the ancestry type stuff that they've done just doesn't have a good scientific base. It's sort of, you see this guy on TV, the African-American guy, in one of their ads, and he says, I found out that I'm from 40% from Central Africa, 20% from Southern Africa, 15% from West Africa kind of thing. And I'm thinking, well, I could have told you that. I didn't even need your DNA. It's sort of, yeah. But there's been a lot of migration. There's been a lot of population movement. It's not clear that trying to interpret where people's ancestry goes based on where people are now is the way to go. And then I'm worried too about who controls the DNA information. So you send it off to a private company. There's the tiny type that we're used to in lots of different agreements to get on the internet and stuff, or use your cell phone program. But it sort of says, we're going to take your DNA and we have your spit and we keep it. And we promise not to do bad stuff with it or release anything about you, but it doesn't mean that it can't be resold or someone couldn't step in and buy them, or we don't have good rules still on the secondary, tertiary use of genetic information. So those are some worries I have.
And I'm going to guess that for all those reasons, 23andMe is not the future of personal genomics. And not just that company, but that model. We're seeing now a number of large health systems beginning to offer to the public at large what they call the healthy genome. That is, they're offering genome sequencing to people who aren't coming in looking for a diagnosis of an existing disorder, but want to be informed about their disease risk in general. In a context like that, you get not just your data dumped back in one bolus, but you get counseling, genetic counseling as to what the implications of the data are, and you get the data fed into your electronic medical record and integrated into your medical care. Frankly, that seems like a much better model, and I'm just going to guess that that's the way we're headed in this business.
And your expertise is in policy, so do we need public policy that guides us in that direction and away from do-it-yourself?
So there's a place for government intervention. I'm not really sure we need it here. I think the market is going to drive this, and I think the advantages of having your physician and your health system do this for you and be prepared to use that data are going to seem so substantial to so many people that's where this is going to move. I think it's going to do it on its own.
Just to jump in there quickly, if it isn't integrated with your doctor and your health system, I don't think it's going to turn out to be that useful. I mean, it's not a curiosity. It's not some sort of fun thing to know your DNA. I mean, you could turn it into that if you want, but for practical reasons, you want it kind of where you get your health care, and that's where I think Paul's going.
Yep.
Yeah, I'll jump in and say that I feel, I'll separate myself from 23andMe right now.
Sure.
And just say that even though the hospitals will be providing a lot of information, I know 23andMe is trying to provide more information, if we have a public that is more aware of what is going on, if that conversation were more vibrant, it may be that, I guess what I'm saying is I don't think we should underestimate the capacity of a public to understand what's going on in genetics if we just make that information more accessible. And at the Personal Genetics Education Project, we often talk about how, in spite of all the policies that may be put forth and all the legal discussions and discussions of ethical issues, in the end, I think individuals make their own personal decision. And if they are more aware of what the issues are, what the opportunities are, and what the pitfalls are, that may be the best form of protection for them.
It may be, although you have some other issues that are cost-driven for justice, meaning 23andMe, they don't have a lot of minority people in their databases. People tend to pay the fee, and they tend to be upper-class whites. And so if you're going to generalize and say, well, this is your risk, and you send your DNA in and you're Indian American or Korean American or Native American, I'm not sure you can generalize out just given the nature of how they build their information source. So I think we can teach people, you do it, to understand genetic information, but you got to make sure in the world of genetics that you have representative samples, that you have sufficient representation to let people then with confidence say, oh, that applies to me.
So I'm glad you brought that up. Participation is clearly key for all aspects, plain research and medicine. So this is anecdotal, but when we go to communities who are fairly well off, they tend to be generally very white, enriched.
And unvaccinated.
We'll tackle that in a moment. And you ask the audience, how many of you have heard of 23andMe, or how many of you have participated in 23andMe? You often see many hands go up. But when we go to communities that are underserved, communities where there's not that much wealth or opportunity, and we ask who has heard of 23andMe, remember this is anecdotal, I can't give you stats on it yet, very few hands, if any, go up. And so part of participation is just knowing what's going on. And I think that, so back again to having that conversation and raising awareness.
And you're dealing with overcoming historical elements of trust in the medical community and scientific establishment in some communities versus others. So you have to what sort of insights do you have in terms of tailoring messages and outreach to different historic contexts, different levels of scientific literacy, different socioeconomic statuses? Is it even possible to do large-scale public outreach without, exacerbating divides?
I think yes. I think it's a lot easier than even I had anticipated when we started this project. I believe that people want to be heard. So when we go to underserved communities, I have experience walking into a room and feeling the anger, just the fact that I'm a scientist, just feeling the wall go up between me and the group. I think scientists sometimes come across as very haughty, very willing to justify our actions. We know better attitude, which is first of all not true. We don't know better. How can we know better about the population if we don't talk to the population? And so what we do is we go into the audience not trying to sell anything. We don't promote genetics. We don't promote technologies. What we want to do is let people know that we have information if they're interested to please come talk with us. And we bring up the sticky social, ethical issues. Sometimes our audience just gets into an argument. But somehow through that argument, having them have voice lowers that distrust and starts a conversation.
So if we're going to reach the general population, I mean, it sounds like you're using face-to-face approaches, but that's limited because you can't get 310 million people in a room with you over time. So at Columbia, one of my colleagues has been developing little videos, and she now has a library of them, Wendy Chung, who
Yes.
you may know, of different aspects of genetic testing, genomic sequencing, the kinds of results that could come up. We've got them in English. We have most of them in Spanish now. They're available online, and they are scalable because things like this can be, creative approaches can be disseminated to the entire population without necessarily requiring people to come into the room where you happen to be at that moment in time.
We love that. I applaud that. We also are, I think we can work with the television and film industry, which we do. Producers and writers of feature films and television, they are, I feel, more and more interested in the genetic world. And they are artists in reaching the community and involving them.
So let me shed a little horror on that, working with Hollywood. Just this past weekend, we saw the HBO documentary come out on Henrietta Lacks. That's a story, for those of you who don't know, of a woman who had a tumor removed in 1951, and basically it was studied and turned into HeLa cells, which are used a lot in research and have been commercially useful to companies as well. Her children and descendants felt that they were not told about what was going on and felt exploited. So the message of this, I think, widely seen show, because Oprah is in it, is that science will exploit you. There isn't much of a discussion of the fact that we did put in ethics rules. We have informed consent for getting samples today. You wouldn't have a Henrietta Lacks situation. Even the book, which is probably the biggest, most widely read book about genetics, Rebecca Skloot's book, ends without discussion of what the ethics protections have been since then. So I worry, I mean, what Hollywood likes too is Jurassic Park. That was pretty scary. I happen to like gene drives. I think we should use them to get rid of, mosquito-borne illnesses, but it's hard to do if everybody thinks that something's going to come out of the sewer and kill them because they just saw it in a TV show or a Hollywood movie.
So, Dr. Wu, you worked with Grey's Anatomy. How did you approach that? Because that show has a tendency, I remember one episode, there was a bomb inside of a gentleman's chest. They have a patient, this was a code black. They have a tendency to, dramatize. How did you steer away from that in working with them?
So I guess I'll say it's a conversation. It's a back and forth. It's a case of checks and balances. I think when people get up and argue, that's great. I think people who've been hurt have a chance to get angry, that's great. So now to answer your question, it took me a while to learn how to work with the Hollywood Health and Society and the Science and Entertainment Exchange of the National Academy of Sciences. These groups put scientists in touch with the producers and writers. In the beginning, I would answer questions. Very often you don't know who you're talking to. It's a very secret process, producing scripts. But eventually I got to know Grey's Anatomy, and the person who was coaching me said, I had complained about a particular phrase, or dramatizing, or shortening the process of a scientific experiment or analysis. And she took me aside and said, okay, you think you know how to do this? And I said, well, I think I could have worded it better. She goes, give me a sentence that will, the way you think this doctor should have said this. So I said it, and she goes, now why are you working with us? I said, because I'm really trying to reach the public in a scalable way. And she said, okay, I just want to tell you, you just lost 3 million viewers by the way you said that. You make a decision. Are you trying to reach people? Are you trying to say it the correct way? And I was convinced. We can fix some of these things. The CDC tracks the kinds of phone calls they get after a Grey's Anatomy show. They have a collaboration. And when Grey's Anatomy touches on a disease, the phone calls to the
Everyone
CDC go
thinks
up.
they have it.
Well, that I don't know, but they call. So, but I hear what you're saying. It's complicated.
You know, we thinking for the future, we also need to think about moving back chronologically on the age span and the ways in which we're educating students in, from elementary school on about genomics and its current understanding and its place in medicine and the world. And all the evidence suggests we're not, in general, doing a very good job with that now, even in college biology and genetics classes. And there's no question the field's moving quickly. Everything I learned in medical school is not just outdated, most of it's wrong today. We now have entirely different conceptualizations of the way the genome works. So this has to be a multifaceted effort. Educational system, the public at large, and physicians as well. We heard in one of the earlier panels just how badly our colleagues do in terms of understanding what the implications of genomic results are for their patients.
So how does any given individual keep up with it? Do we need policy implications for medical education, for public schools to integrate genetics? I mean, what's the solution?
Well, there's no. I don't think there's one solution. Right. Clearly, educational, and there's no unified educational policy in this country. Right. So school boards, school districts, states need to take the initiative in recognizing the importance of this material and developing curricula or engaging scientists and thought leaders to develop curricula to make sure that it's done well.
I think that scientists fail their moral obligation to engage the community. For every one of these experiments in public education, there are thousands of scientists who say, I don't do that. I don't talk to the public. I don't get involved. It's not my job. We just had the greatest nerd march ever seen in Washington, which was good, but we haven't seen that before. A lot of people said we shouldn't be political. My view is, of course you have to be political. You have to fight for money to be spent on you. You don't have to be political in the sense of, getting into debates about policy, about how the information is applied, but you've got to be political if you want the public to support it. We're seeing the results of sort of hiding in the ivory tower. They won't, and especially if they don't understand it. So a key step for me is, where's the public understanding of science? Where do we train scientists to write that sentence or communicate more clearly? Now, not everybody's good at everything, I understand that, but at least some pathway. I'll end this little screed by saying we have a bioethics program at NYU. If I go to the basic science department, not the doctors, but the basic science department, say I'd like to have somebody spend a month or 6 months learning about the bioethical issues so they can engage in the debate and communicate about them, the lab director is going to go out of his or her mind and say, a month away from the bench? Absolutely can't happen. It's ridiculous. No, it's, and we don't want that. So we don't have the troops. People say, well, there's Carl Sagan and there was Stephen Jay Gould and there's, other prominent scientists who do this, but you could name them on 2 hands. That's not enough.
Well, I could, there's a little uptick. There may be a slight change in our culture. So the PG Ed, which I direct, actually is a nonprofit part of actually my whole lab is nonprofit, but it's a part of my research lab. And several years ago, we sort of lived off some of the funding I was able to scrounge up. We were about to go under. And the chair of my department, Cliff Tabin, it is a research department, came to me and said that he felt the obligation to reach the public was especially important in genetics departments. And he diverted a large sum of research funding to support reaching out to the public. And I feel in the past few months, there's been a slight change. When I go give research talks in other departments of genetics, I've had faculty and students come up wanting to do a similar thing. I think geneticists, in particular geneticists, are starting to feel and starting to act on this sense of responsibility. So maybe it's going to get better.
So there's a level at which we're not doing that today that maybe we need to think about doing it, and that's at the National Institutes of Health. If you talk to program directors up to institute directors, they'll tell you that public education is not their mission, that their mission is supporting research. Some of them, if they're being blunt over a beer, will say that public education is a sinkhole. You could pour infinite amounts of money into it, and they just don't have the funding to do it. Well, you know, maybe that's not the right attitude for the 21st century. Maybe public education has to be part and parcel of what NIH and related agencies like NSF, National Science Foundation, can support. It may be just that important now that they should be doing that.
Yes, and I think that is starting to change at NIH too. It's a really encouraging time, I feel. We can't stop. We have to scale and escalate this.
I'd add a plug for journalism too.
Yes.
Just making yourself available for comment and being on social media. It's so easy. You don't have to launch a huge program to start a Twitter account and engage. Yes. When I was doing my residency at UCLA, Twitter was blocked. This was in 2012, but you couldn't. It was a UCLA Medical Center. You couldn't use Twitter on any of their computers because it was a waste of time. And maybe it is, but there are many legitimate uses that I think medical establishment is sort of coming around to now late in the game when they say, like, why does Trump have 20 million followers?
We even try to get people, and I think the medical school is a little bit easier than the hard science line right now, but it's sort of, you should be able to graduate with a PhD or an MD and at least write a letter to the editor that's cogent, or an op-ed piece, or put together a blog statement. It's a skill set, and we ought to empower people to have those skills too. They are communicators. It's part of what I think if you take public funding, you should give back to the public. We now insist that you make your results available at clinicaltrials.gov, but that's nice, but I think relatively few people will go there to read them. So being able to communicate information about what you're doing.
And there are models. So for example, in our residency program, there's an elective course that the residents can take that culminates in their writing an op-ed. Now they may or may not get it published, but the idea is there are journalists involved and psychiatrists involved to teach them something about how to communicate with the public. And that is something that, it's great it's in one program, but there's no reason why physicians and basic scientists couldn't have similar experiences during their training.
Yeah. It seems like a requirement of a lot of these events that we end on. The solution is public education. So we're here right now. But we kind of skipped over discussion of the ethics of what I hear a lot when I'm talking to people who don't know as much about genetics, and that is sort of the designer baby question, the end use of genome editing, the potential worst case scenarios. So I think that's a good question for at least people in the room to consider how to respond to and how to think about. How do you talk about that when you're having dinner with a friend who's not an expert in
So
this?
it's important to recognize there are two broad uses of gene editing in humans, right?
Yeah.
One is to edit somatic genes that are disease-causing in an effort to treat a disorder that somebody has. And the second is to edit the germline to prevent that person from passing on a predisposition to a disorder to their offspring. With all the controversy over gene editing, that first use for the treatment of existing diseases tends to be relatively uncontroversial, and I think that's important to recognize.
By the way, I have to add, somatic cell gene editing is not controversial, I would agree, when it's in humans. It's hugely controversial when it's plants or animals.
Because we're messing with nature?
Yeah, and we're used to the idea that medicine intervenes with us, but if I say, how about GMO food? We're going to, alter some genes and make healthier food, or food that can fight off pests, or we're going to make animals that will have less waste or less nitrogen in their waste or whatever. People are, well, I don't know that you should do that. You can engineer me,
Right.
but not my dog.
Well, why is it that people tend to take, I guess, these black or white, I'm for editing or a not type statements instead of the use case scenario type, if we could use it to cure this disease or this one particular case, but I also wouldn't want to make designer babies. How do you
Well,
sort of get people
we
to
talked a
navigate
little
that?
about history, and in human germline engineering, changing our reproductive future, we have a past. It's the Nazi race hygiene eugenics programs, it's sterilization programs, bans on interracial marriage in various states in the US and countries. We have a pretty grim past with respect to controlling reproduction when it comes to genetics. It's not good. And it casts a shadow over how we think about where we're going. On the other hand, it does seem to me you want to make sure that people are focused on gene editing, as Paul said before I interrupted him. You're going to try and fix diseases, whether it's somatic cell or hereditary, passing on hemophilia, passing on other terrible genetic afflictions. That seems to me to be where the focus is. I don't think we need to argue about how tall we should engineer our babies or whether we should make them with supervision or, powers beyond imagination. We're not there yet. That's an issue for one generation, maybe two away right now. But trying to come up with the rules about how to safely proceed to fix disease, whether it's somatic or germline, that seems to me to be the way to get the public involved and calm about it.
And to your question, why are people as upset in black and white about it as they are? I think we're dealing with a slippery slope perception here, that once you start fooling with the germline, that there's no stopping point. But of course, we can create stopping points. We don't have to go from editing a predisposition to Huntington's disease to editing eye color or running ability, athletic ability. We can come up with reasonable rules, as I think Art is suggesting, and begin to address this. And frankly, I think it's inevitable that we will, because the technology, once it's perfected, is so powerful that it's almost inconceivable that it won't be utilized.
And a little twist to that is whether when we have these discussions and set up these rules, whether it's an international effort or separate nation by nation.
We have time for 2 or 3 questions.
Hey, how are you? My name is Lippy Roy. Thank you for the fascinating panel. I'm an internist and an addiction medicine doctor. I oversee addiction efforts at New York City jails, including Rikers. I'm a strong advocate of technology, science, and innovation, but I think it's really important to take that into consideration with the complex medical and psychosocial aspects that affect health. So prior to this role, I was a doctor of Boston's homeless population. Leading cause of death is drug overdose. So you can treat their cancer and their Alzheimer's and their Huntington's, but if you don't recognize that they're more concerned about their next meal or where they're sleeping tonight. So how is the best way or most effective way to leverage, the power and authority and funding sources of, like, say, industry and government to really recognize that these other aspects of health matter in terms of health outcomes? Thanks.
Well, I'll jump into that because I have sympathy for that comment, in that I think when we get obsessed about genetics, we overlook the fact that one way to treat your asthma is to clean up the air, not just engineer your lung cells or something like that. So it is still true that for a lot of Americans, they don't have basic health care. Genomics a little bit looks like a luxury. If you have, empowered, you have resources, you can go worry about minor genetic risks, but clearly for most people, they want to manage their diabetes or be able to access healthy food or be able to get some exercise somewhere or manage their drug problems, have a safe place to sleep and so on. Those still have to be the priorities, I think, in the health system and how we spend our money. I'm not against moving us along genetically, but we don't have a system that would get the best yield for the dollar right now in terms of health. That remains a problem.
This stuff is a tool, the things we're talking about today, right? Just like an MRI machine is a tool. Nobody expects MRI to solve all the problems in healthcare. And we have to be careful not to oversell personalized genomic medicine, right? It's not going to solve all the problems in healthcare for exactly the reasons that you point out. So it's one more tool, keep it in perspective. It's not what we're going to spend all our money on, but it's conceivable that for some substantial number of people, this could be a very useful tool.
Yeah. Another question? Someone over there? Oh, sorry, back here.
Hi, I'm David Keefe. I'm from NYU Langone Medical Center. I have a question about communicating genomics information. We were taught in our medical training, first do no harm. But words can be like knives. They can be like scalpels. I can remember how I was trained to do ultrasound when it was beginning, back when I was a trainee at Yale. And I remember the way not to do it, which was to say, oh, wait a minute, there's something there. Oh, looks like cancer. Oh, no, forget that, not cancer, just a tumor. No, it's nothing. So that's how not to do it. How do you communicate these sort of continuous outcomes, the risk, when people don't really think that way?
So there are so many terms, statistics, that make it difficult to discuss genetics the way we think it should be discussed. We have found that the biggest problem is getting people to want to even have that discussion. And so when we go to communities, I almost never say GATC, I never say dominant recessive, I rarely actually talk about a specific variant for a disease. I simply talk about the ethical social issues, especially in communities that have been disenfranchised. They start discussing whether it's good or bad, and that leads to questions that are relevant to them. And then I know what actually to answer for them. These days, for communities that not all of them have the ability to get to the internet, they then can go get that information. But we find the most important thing is to make it a safe conversation and one where they feel totally involved.
And although at first there was a lot of concern that giving genetic genomic information back to patients would be upsetting to them, provoke depression, suicide attempts, and this is what people were worried about when people found out about predispositions to future illness. That seems to have been markedly overblown, if you will. People do reasonably well with this information, and so our communication should be good, but it doesn't have to be perfect. We're not going to destroy people's lives by using the wrong word to communicate the findings.
We can do one more? Yes.
Hi, I'm Lisa. I'm a consumer. I think there's tremendous value both in terms of understanding as a consumer how I can make behavioral changes to be healthier longer, as well as getting vital treatment if I need it. But this information feels like it could also be very damaging in terms of the cost impact of just when I may find out I need care, my health insurance or my supplemental health insurances become unaffordable to me because I just became a high-risk person. What are your thoughts about the ethics and the balance of the cost versus the knowledge that consumers will be able to have in the future?
Well, remember, a lot of the burden of protecting against discrimination or adverse events from finding out genetic information, we hoped would be solved by passing laws like GINA, the Genetic Non-Discrimination Act for health insurance. That's helped. Obamacare did have its pre-existing condition restriction that you shouldn't try to underwrite out people with prior problems, and I think that's useful, although we'll see if it endures, but I think it's a good thing. It's trying to share the risk in the community, basically, rather than assign it to those who know they have risk. But there's still problems with disability insurance. There's still problems with things like life insurance. There's still issues about employment, depending on where you are, small employers versus bigger ones that are covered by these protections. So I know Jim was interested in sort of things we could do. If you want to see genetic testing flourish down the road, I do think you have to repair some of these, through legislation, some of these adverse consequences of going out to get or to know information. We've even had situations where in some parts of the world, people won't marry somebody else unless they take a genetic test, because they're worried that they pay for the hospitals. I'm talking about the island of Cyprus here, if any of you are interested, at least the Greek part. And the Greek Orthodox Church runs the hospitals, and they don't want people getting thalassemia and other costly genetic diseases. Now, I'm not saying it's necessarily wrong to do that, but you want to debate that kind of consequence and sort of saying, you know, I can't get married in the church because, is that okay? Down the road, genetic discrimination could extend to, I'm an Ashkenazi Jewish woman, I'm at high risk of breast cancer, so I'm going to underwrite out the whole group, not the individual, but I'll just penalize a population. So I know you were looking for some answers. These are places where I think work reasonably can be done that won't hinder the evolution of genetics, but would help it.
And in terms of what you can do today, there's a new proposal out for abrogating the Affordable Care Act. It came out while we were here this morning. If you haven't contacted your Congress people about this yet, go do it, because we're moving backwards if we go in that direction rather than forwards.
On that note, thank you so much to our panelists, Dr. Caplan, Dr. Appelbaum, Dr. Wu.